Hello, and welcome to the session on behavioral economics and conditional incentives to strengthen HIV treatment and prevention, actioning the science. I'm Diane Rausch, and I'm the director of the Division of AIDS Research at the National Institute of Mental Health.
Hi and welcome. I'm Rachel Stirk. I'm the Deputy Director of the Center for Global Health Studies at the Fogarty International Center at the National Institutes of Health. This satellite session at the AIDS 2022 conference will examine the use of behavioral economics and conditional cash incentives in HIV treatment and prevention programs, and it will identify strategies to support their further advancement and use. Behavioral economics and conditional incentives have been used to strengthen healthcare engagement and health outcomes by providing small incentives or nudges to encourage health behaviors, such as attending routine clinic appointments. Although a growing body of research evidence indicates that these strategies can be impactful when done well, adoption of these approaches in real-world HIV treatment and prevention programs remains limited. This session will therefore explore the state of the science and practice of behavioral economics and conditional incentives in HIV treatment and prevention programs with an eye toward understanding the factors that could strengthen their impact and promote their effective use.
The satellite will take place in two parts. It will open with research scientist Dr. Harsha Thayamurthy from the Center for Health Incentives and Behavioral Economics at the University of Pennsylvania, who will review core concepts in behavioral economics and contemporary forms of conditional economic incentives, as well as their mechanisms of actions. And Dr. Sandra McCoy from the University of California, Berkeley, who will present the evidence base for their impact in the HIV treatment and prevention continua. The symposium will then highlight examples of real-world HIV treatment and prevention programs that currently integrate behavioral economic or conditional incentives into specialized clinics or routine services, specifically in Galila in South Africa, presented by Dr. Sophie Pascoe and Candice Chetty McCann from the University of Witwatersrand, and Seattle in the Seattle Max Clinic, presented by Dr. Julie Dombrowski from the University of Washington.
The second part of the session will be a multi-sectoral panel with researchers, technologists, and government and public health officials. These will include Omar Galarraga, Sebastian Linnemeyer, Catherine Godfrey, Natalina Mwenda, and Prosper Niao. The panel will be facilitated by Michael Stirrat and Susan Vorkoper. This group will discuss moving from research to program and policy and key directions for further research and implementation of behavioral economic and conditional incentives in HIV treatment and prevention delivery.
This session has been pre-recorded, so you're unable to take questions from the audience. We'd now like to welcome our first 5 speakers, Dr. Harsha Thayamurthy, Sandra McCoy, Sophie Pascoe, Candice Chetty McCann, and Julie Dombrowski.
I'm delighted to have this chance to talk to you today about what are conditional incentives and behavioral economics approaches more generally. I'm going to review today a few of the key concepts that I hope will be relevant for framing the rest of the discussion. So it's fair to say, I believe, that the success of HIV treatment and prevention depends very crucially on human behavior. The treatment cascade is a good example of all of the different places in which human behavior becomes relevant for ensuring that treatment not only is successful in protecting and improving the health of people living with HIV, but also that treatment is effective in reducing the risk of HIV transmission. So people have to make decisions to take an HIV test and then initiate treatment, or they have to make decisions to remain in care and take their medications regularly in order for treatment to be effective. Again, reinforces the role of human behavior in ensuring the success of treatment and prevention. Before I talk about behavioral economics approaches, I want to just review briefly the standard economic approach that many have used to both understand human behavior and to change behavior or to promote behavior change. And one of the critiques of the standard model has been that rational decision-making is often not a very good way to understand and describe that behavior. So in the conventional model, simply giving people health information about what's good for them or bad for them is sufficient to promote behavior change. So in that conventional approach, if you want to change someone's behavior, You simply need to change their mind. You need to educate them about the dangers of smoking, for example, or you need to simply communicate the risks of HIV or the benefits of HIV treatment. But of course, we know from simple introspection that this is often insufficient for achieving behavior change. The behavioral economics insight, or the key element of behavioral economics research, has been to really demonstrate that the mind is, in fact, in this analogy, a very, quote, high resistance pathway. So simply giving information is not sufficient to change behavior. And in fact, if you wanted to change behavior, a better approach might be to use various types of behavioral reflexes, so to speak, and bypass cognition if you want to change behavior. So the behavioral economics toolkit is filled with lots of different examples of nudges and changes in the way that people are presented with choices. And those types of nudges and changes in choice architecture have been shown to be quite effective in changing their behavior. There's, of course, lots of different examples of these types of interventions, and I'm not going to be able to review all of them in today's presentation, but I do want to give you an overview of some of the key insights that have been important. And it's worth recognizing here a report that was published in 2017 that looked at the role of human behavior in achieving changes in lots of different outcomes when it comes to poverty and health. And one of the key insights of behavioral economics has been that human behavior can often be thought about the product of people making decisions in certain ways that suggest they either think automatically or that they think socially or that they use mental models when they make decisions. I'm going to very quickly review these three different ways of understanding human behavior. One important contribution of behavioral economics has been to recognize that people sometimes have present bias preferences. What we mean by that is that when people make decisions, they're often persuaded by the immediate costs and the immediate benefits that come to their mind, and that they often end up discounting a lot of the future costs and benefits of behaving in a certain way. Those future costs and benefits get discounted in a very substantial way, particularly when they're faced with the actual decision they have to make. This explains why, for example, it's quite difficult to change behaviors in which there's a substantial trade-off between the immediate costs and benefits and the future consequences. Smoking cessation and regular exercise are good examples of behaviors in which this type of trade-off comes into play. But within HIV, there's also lots of behaviors where this trade-off is also present. So thinking about the take-up of medical male circumcision or the usage of HIV prevention services, for example, suggests that there are indeed these very dramatic trade-offs that people face. One way that behavioral economics suggests we might be able to counter this decision-making, this factor of decision-making, is to offer people incentives. So offering simple, immediate rewards can often shift the behaviors, the benefits of behaving in a certain way to the present, and thereby change human behavior. It's important to recognize that this rationale for offering incentives is quite different than the rationale that is suggested by traditional economics, which is simply that giving an incentive will reduce the immediate costs of behaving in a certain way. And so the behavioral economics rationale for incentives is really driven more by the fact that people may have present bias preferences. Behavioral economics also suggests that incentives can be offered in a lot of different ways, and the way in which incentives are designed actually has quite significant consequences for whether those incentives are effective. So whether an incentive is presented as a guaranteed reward or if it's presented as a lottery-based reward may have implications for whether or not the incentives work. But another example of how people think automatically, and it's important to really pivot here to talking and recognizing not just incentives as one of the interventions that is part of the behavioral economics toolkit, but also a lot of other interventions. An example is default settings in the choices that people have to make. One study done in the US at a health system showed that when physicians were presented the generic version of a drug as the default, their prescription rates went up considerably. So prior to the default setting, prescription rates of generic drugs was quite low, but the moment that the default prescription was changed to the generic version of the drug, we saw nearly universal prescription rates of generic drugs. So this study shows that simply changing the way in which choices are offered to individuals can make a big difference. And in fact, it explains why, for example, the pivot to opt-out testing or the initiation of same-day ART initiation policies also made a big difference in improving HIV outcomes. Finally, it's worth recognizing that people also rely on social norms and social networks when they make decisions. Exploiting this insight actually can lead to quite a difference in behavior. One important study that was quite influential and showed the power of social norms was done in the US and focused on the topic of water and energy conservation in hotel rooms. So in the control arm, people were basically given a standard encouragement that said they could protect the environment by reusing their towels, whereas in the intervention group, people were told that almost 75% of guests who were asked to participate in this conservation program chose to do so. And in fact, the study found that people who were simply told the descriptive norm were much more likely, significantly more likely to reuse their towels than those in the standard or the environmental protection condition. So again, this study and the broader insight from behavioral economics is that we really ought to be thinking about ways in which we can seek to inform people about social norms and also rely on social networks in order to influence decisions. The other insight from behavioral economics is that when people make decisions, they often use mental models. That is to say, they use causal narratives or rely on their own intuition when they seek to both form beliefs and make decisions. And there may be biases in the way these mental models get formed. So availability bias is a bias in decision-making, which suggests that people form beliefs and make decisions on the basis of what immediately comes to their mind when at the time of decision-making. So in the early stages of the AIDS, the HIV epidemic, when people did observe that a lot of people with HIV were dying, people formed very pessimistic or overly pessimistic expectations about mortality. And correcting these beliefs about mortality can take time and is indeed an important priority for HIV policymakers. People also have incorrect mental models about transmission of HIV. A study done in Uganda showed that for men, the belief that HIV could be transmitted from one person to another in a serodiscordant couple actually tended to be quite incorrect, even if the person living with HIV was taking ART. So we know from the scientific evidence that taking ART can nearly shut down the risk of HIV transmission, but many men actually still believe that despite ART, the risk of HIV transmission remains quite high. So correcting this mental model about how people believe HIV is transmitted or how likely it is that HIV gets transmitted when people are taking ART is an important priority. And indeed, some interventions such as the U=U intervention might be effective in changing those mental models. Lastly, I just want to draw attention to an important overarching framework for thinking about human behavior. And this comes from several studies that have shown that poverty has far broader impacts than we previously recognized. So not only does poverty make it harder for people to afford health services, but it also captures their attention and may even lower their cognition. So this type of influence of poverty suggests that people who are experiencing poverty or experiencing economic constraints may actually underutilize or deprioritize their own health. One of the key implications of this scarcity hypothesis is that as policymakers and researchers, we ought to be thinking about different interventions that can not only reduce poverty, such as cash transfers or basic income interventions, but also that we should be paying attention to how we can make the delivery of health services more automatic and easy for people, and thereby increase the usage of those health services. We should also be thinking about lots of nudges, such as simplified forms or usage of reminders, and we should be thinking about changing the default settings that are in place in clinics and in the access to health services if we want to promote greater usage of services.
Hi, everyone. My name is Sandy McCoy, and I'm at the University of California, Berkeley. In this presentation, I'll characterize the state of the science on incentives and other behavioral economic approaches to bolster HIV prevention and care. These strategies are theorized to nudge engagement in beneficial health-related behaviors and services and initiate a positive domino effect that ultimately leads to better health outcomes. Over the past decade, research on incentives and other behavioral economic approaches for the global HIV response has significantly matured. This is a graph demonstrating the dramatic rise in HIV-related publications referencing behavioral economics, incentives, cash transfers, or other related terms, with more than 60 publications on these topics in 2021 alone. Of course, the vast majority of these publications focus on conditional economic incentives. Indeed, 98% of these publications refer to at least one form of incentives in the manuscript. For that reason, the next section of my presentation will focus on the evidence related to economic incentives. It's challenging to summarize such a rapidly growing literature, but fortunately, in the past several years, there have been multiple systematic reviews focusing on the use of incentives for various stages of the HIV cascade, primarily focused on low and middle income countries. I'm grateful to these authors as I'll rely heavily on their searches and interpretation of results in this presentation. Of course, each review has a different focus and inclusion criteria, and there's significant heterogeneity across all incentive studies in program design, outcome measurement, and context. For those reasons, I conducted a qualitative review of the evidence to date, listing the key reviews for each cascade domain in the figure on the slide. Let's begin with HIV prevention, where common incentive approaches include unconditional and conditional cash transfers, savings programs, and programs to reduce school costs. Across a diverse literature, there is moderate evidence for incentives' impact on HIV prevalence or incidence. 8 studies have included biomarkers for HIV, but only 3 reported a significant reduction in HIV incidence or prevalence. Despite 18 studies examining incentives' potential impact on reducing higher risk behavior, there's a low level of evidence to support a strong effect on sexual behavior change. Furthermore, despite promising results from several RCTs of incentives for voluntary medical male circumcision and PrEP, the evidence base for these strategies remains very limited. The most compelling evidence for incentives' effect on prevention-related behaviors pertains to sexual debut, with 10 of 18 studies included in a 2021 Stoner review reporting delayed sexual debut among beneficiaries, with effect sizes strongest for girls. And in contrast to programs providing incentives for specific behaviors, a forthcoming ecologic study of large-scale cash transfer programs for social protection in 21 countries finds that government-run cash transfer programs may reduce HIV incidence, with effects modestly increasing each year after introduction of the cash transfer program. Now let's consider the state of the evidence for incentives and HIV testing, where there's a diversity of economic incentives that have been studied, ranging from demand-side fixed monetary and non-monetary incentives, lotteries and cash transfers, as well as supply-side performance-based financing programs. There's a high level of evidence for improving HIV testing uptake with incentives based on the 5 randomized controlled trials included in the Krishnamurthy review. In some settings, monetary or non-monetary conditional economic incentives more than doubled the uptake of HIV testing. In addition, 2 of 4 studies of performance-based financing reported increases in couples testing in Rwanda and testing among pregnant people in Côte d'Ivoire. And the previously mentioned ecologic study of large-scale cash transfer programs reported significant increases in the likelihood of HIV testing in the prior 12 months in countries with cash transfer programs. The literature on incentives and linkage to care has focused on monetary and non-monetary incentives. Overall, there's currently a low level of evidence supporting the potential benefit of conditional economic incentives on improving linkage to initial HIV care. Only 1 of the 4 experimental studies reported higher linkage in the incentive group. 2 of the 4 studies had less than 150 people, and the largest study in Eswatini reported a very small, non-significant effect on linkage to care. Notably, all 4 studies focused on initial linkage after diagnosis. None focused on care re-engagement. This is the focus of an ongoing effectiveness study in Tanzania that will evaluate the potential benefit of using incentives to re-engage people with HIV care. Now let's consider the state of the evidence on incentives' potential benefit on adherence, retention and care, and viral suppression. In this area, most studies evaluated monetary and non-monetary incentives, including escalating incentives. Other studies evaluated performance-based financing. Overall, across diverse studies and settings, there is a high level of evidence for improving ART adherence with incentives. The forest plot on the right synthesizes 6 randomized trials evaluating various types of incentives on several metrics of ART adherence, and many of them report a strong and precise measure of effect. In their meta-analysis, Krishnamurthy et al. Report a pooled relative risk of 1.3, indicating that incentives are associated with a 30% increase in the probability of high levels of ART adherence on average. In contrast, there is only a moderate level of evidence of incentives' potential benefit on retention and care, primarily due to a smaller evidence base. That said, of the 4 randomized trials to date, all reported modest benefits on retention. Although not included in reviews of demand-side interventions, one supply-side study of performance-based financing in Côte d'Ivoire reported reduced attrition from care. Performance-based financing's positive effects on attrition might be related to making provider behavior more acceptable to clients, thereby improving patient satisfaction and increasing utilization of HIV services. Now let's consider viral suppression, where there's a moderate level of evidence for incentives' potential benefit. Across 10 randomized trials included in the Krishnamurthy review, the pooled risk ratio is 1.08. However, not included in this review is one of the larger studies in this group evaluating conditional economic incentives for viral suppression among ART treatment initiates in Tanzania. The study found a 13 percentage point increase in viral suppression at 6 months. In addition, one study of performance-based financing in Kenya reported a significant reduction in ART treatment failure. Taken together, we can see that there have been numerous rigorous studies in this domain, but heterogeneity across study findings and a modest pooled effect estimate leaves uncertainty about the benefits of incentives for viral suppression. Based on these findings, I categorized the quality of evidence for each cascade domain and assigned a level of certainty to our current knowledge, following an adaptive qualitative grade approach for evidence synthesis. The evidence for whether incentives can enhance HIV prevention is mixed. There's moderate evidence to suggest that incentives may reduce HIV incidence and delay sexual debut. There's a low level of evidence that incentives consistently alter various metrics of sexual behavior. The evidence for whether incentives can bolster HIV testing is high. Multiple RCTs in diverse settings using various incentive approaches have consistently reported the benefit of small incentives on increasing HIV testing uptake. The evidence for incentives benefit on linkage to care is low. This is primarily due to the lack of studies in this domain, including several small studies and inconsistent results. Finally, the evidence for incentives benefit on HIV care and treatment is mixed. There's a high level of evidence from multiple randomized trials that incentives improve ART adherence. However, there's only a moderate level of evidence that incentives improve retention or viral suppression. This qualitative synthesis relied heavily on existing summaries of the evidence base. Please keep in mind that even within a single cascade domain, there's significant heterogeneity in the incentive type, size, and context, as well as the definition and measurement of the primary outcome. In addition, some recent studies may not have been included. There are several knowledge gaps for future research. First, we need to know more about in which groups incentives work best. The field lacks data about incentives' effect in many vulnerable populations and geographic regions. Second, we must contend with the issue of effect durability and in which circumstances it's reasonable to hope that an incentive intervention should have long-term effects even after being withdrawn. This discussion should include consideration of the emerging long-term data about prior incentive programs. Third, we need more research on how to best tailor incentive models to the desired health outcome and context. This includes the central importance of informed decision-making, the possible role of combination or cash plus programs, and understanding why incentives work in some settings and not others. And finally, we need much more research on scalable implementation models to amplify the potential impact of incentives on HIV prevention and care. Although incentives can often be a lightning rod, there is growing rigorous evidence that incentives should be considered as part of the standard toolbox of potential strategies to accelerate goals to end the HIV epidemic. The use of effectiveness implementation designs will be essential to narrow remaining knowledge gaps and accelerate the pathway to scale. And lastly, the broader toolbox of behavioral economics approaches is very underutilized and represents a significant opportunity for the next generation of behavioral economics interventions that could be delivered at the individual provider or program levels. I'll leave you with a brief mention of a few exciting behavioral economics projects where incentives are not the main ingredient. The Baobab Intervention in Tanzania improved ART adherence through a combination approach based on social norms feedback and visual priming. People living with HIV exposed to the intervention were significantly more likely to be in care after 6 months and were more likely to have high levels of adherence. The motives and CETA interventions are text-based interventions targeting salience and present bias. The CETA study, for example, found that ART adherence among Ugandan youth increased when they were provided with information about the group-level adherence of their peers. Lastly, the Multi-Sectoral Intervention is a loyalty program for young women who can earn mystery prizes by shopping at drug shops, and they can discreetly request free sexual and reproductive health products like HIV self-test kits. The effectiveness trial of Multi-Sectoral is currently ongoing. I look forward to seeing more interventions like these in the future using the full behavioral economics toolbox. Thank you so much for your attention, and I'd like to thank the symposia organizers for the invitation to present, and thank the authors of these reviews who made the presentation possible.
Good day, everyone who's joining this session, and a thank you to Rachel Stirk and Diane Roche and Mike Stirrat for inviting us to be part of this session. I'm Sophie Pascoe from the Health Economics and Epidemiology Research Office here in Johannesburg, and I'm co-director with Harsha Thirumarthy of the Ndlela unit, which is a behavioral economics nudge unit that we've established here in South Africa back in 2020. And I'm joined by my colleague, Candice Chetty-Macken, who is the Senior Behavioral Scientist at Ndlela. I can declare that we have no conflicts of interest. And our aim today is to try and give a brief overview on why we have established Ndlela, our overall vision and aims and insight into how we meet our objectives, and a quick review of some of the behavioral insights research work that we've done and that we're looking to do in the future. So why did we look to establish a nudge unit that focused on HIV in South Africa? Well, I suspect that most of the audience will know that for the most part, the South African HIV response has been very successful in terms of its progress to reach the original 90-90-90 targets, and particularly in respect to the first and third 90. But human behavior really does pose that last mile challenge to ensuring the effectiveness of those existing health services and then maximizing the impact of available resources. And as we've heard both today and from other sessions at this conference, behavioral economics offers insights on human behavior and decision-making that can be useful for identifying low-cost behavioral solutions or nudges that can increase uptake of health services and promote behavior change more generally. We also know that over the last decade or so, a number of governments and health systems globally have started to use behavioral science and rapid testing of interventions to try and improve efficiency of programs by forming nudge units or units that are informed by behavioral insights that can be applied to public policy and used to help develop low-cost interventions that can improve healthcare delivery. This OECD map from 2018 shows the extent of nudge units that have been established around the globe, only a few of which are probably focused specifically on health. But in all likelihood, there are also probably now many more of these units. But what this map does show is the predominance of these units in the Northern Hemisphere, with only a few units established on the African continent. So in 2020, following various conversations between HERO and our colleagues at the University of Pennsylvania and with support from the Bill and Melinda Gates Foundation, we launched Ndlela Behavioral Insights for Better Health in South Africa as a first of its kind nudge unit that focused specifically on improving the effectiveness of the public sector in delivering healthcare and achieving better health outcomes in South Africa. And our aim was to achieve this both by expanding the knowledge and use of behavioral economics within HIV prevention and treatment programs, and by strengthening the ability and technical capacity among health service providers and key research institutions to develop and test contextually appropriate interventions that are informed by behavioral science principles. So what has it taken to establish a nudge unit like Ndlela? Well, first we had to establish and grow our team, and we're really excited to have found and recruited a team of superstar behavioral scientists who are now also building their technical capacity as behavioral economists and supporting and leading the research work that is being done. In addition to that, we were also able to establish an impressive external advisory board, which includes a number of experienced behavioral economists, but also key stakeholders from research organizations, government, funders, and civil society. And we're very grateful to be able to benefit from their combined experience and their guidance with regards to strategic direction and also priorities within health and HIV service programs. We have also focused strongly on building our communication platforms, and we now have a dynamic website, which includes a growing list of resources. And we also share quarterly newsletters with highlights and links to other resources. And you can also follow us on Twitter. And as we try to build our community of practice, we've also set up a WhatsApp group where we share information and conversations with all those who wish to join. In terms of building technical capacity in other institutions and developing and testing behavioral economic solutions, we have run webinars and a series of workshops that focused on developing ideas for rapid behavioral insight tests and applying the nudge framework. And we released a request for proposals, and through that we've identified a number of project ideas for rapid testing. And we provide both small grants for those projects as well as technical support to the partners that are implementing those projects. And with that, I'm going to hand over to Candice so she can tell you a little bit more about some of those projects. Thank you.
Okay, thank you, Sophie. So Ndlela is currently supporting 6 behavioral insights test projects, and these projects are rapid, low cost, and designed with our implementing partners. We are supporting one project that uses conditional economic incentives. However, most of our projects leverage different behavioral economics principles in the design of our interventions. We use the nudge framework to narrow, understand, discover, generate, and evaluate our projects. We are proud to announce that we launched our nudge handbook at Ndlela's satellite session that was entitled Nudging Our Way to 95, 95, 95. As part of all our projects, we prototype the interventions prior to implementation. I will give you an overview of 3 projects where we have recently completed data collection, and we are in the process of data cleaning and analysis. So please look out for our results that will be coming soon. I will also highlight the progress on the setup of our consumer panel. Our first project was done in collaboration with the Aurum Institute. The primary outcome was a clinic visit on or before the day of a scheduled appointment. We assessed if mobile phone-based text messaging that leveraged behavioral economics principles such as social norms, loss aversion, and altruism could improve timely clinic attendance. Our second project was done in collaboration with Right to Care, Palindrome Data, and Hero. The Predict project focused on using machine learning and individual aggregate data to build a predictive model that identified individuals on ART who may be at high risk to loss to follow-up. Palindrome data developed an algorithm to predict an individual level risk score for loss to follow-up. The scoring system or algorithm alerted clinicians to the risk profile of individuals and allowed them to tailor care based on the individual's risk score. We leveraged the behavioral economics principles of present bias, choice overload, ostriching, optimism bias, and ambiguity aversion to design the treatment referral plan. Based on the risk score, clinicians tailored care for their care recipients using the treatment referral plan. The outcome that we measured was return to care within 28 days of a clinic visit. Our third project was done in collaboration with the Foundation for Professional Development and focused on low HIV testing at GP practices in Gauteng province. We used behavioral insights to design a demand creation material where we compared standard of care material to a healthy lifestyle brochure and to a brochure highlighting the monetary value of the HIV test. During the intervention, the isiZulu vouchers were misinterpreted by some who believed that they would receive 100 Rand if they came in for testing. The lesson that we learned was the importance of using appropriate local language on printed material. The primary outcome that we measured was the number of individuals presenting at a GP practice for HIV testing. One innovative project that Ndlela is working on is setting up a consumer panel. A consumer panel is a group of individuals that we enroll to give feedback on behaviorally informed interventions before projects are evaluated in clinic settings. We use lessons learned from Busara and MTurk to set up our consumer panel in the Gauteng province. We will be enrolling care recipients, community members, and healthcare providers to take part in online surveys, telephonic interviews, or focus group discussions. Please visit our website and sign up for Ndlela's newsletter on upcoming results from our projects. Please feel free also to connect with us via our website, email, Twitter, or WhatsApp. And thank you for your attention.
Hello, I'm Julie Dombrowski from the University of Washington and Public Health Seattle and King County. I'm excited to be part of this satellite session at AIDS 2022 and talk today about a real-world example of operationalizing incentives in the Max Clinic. I'll talk first a bit about the context of the Max Clinic, discuss logistics of incentives, address evidence for impact in our population, and finish up with lessons learned. The Max Clinic in Seattle, Washington is an example of a low barrier HIV clinic that's designed to engage people with HIV who haven't been well engaged in conventional medical care. It's an example of differentiated service delivery as a high intensity intervention for people with a higher level of need. The Max Clinic model and low barrier clinic model is very adaptable to various conditions and settings, but there are a few core elements, of which incentives is only one piece. As you can see in the table here, the structural elements, there are three key ones. First, walk-in access to HIV care. Patients who are enrolled in the Max Clinic get HIV care and primary medical care entirely on a walk-in basis. Second, integrated high-intensity case management, both medical and non-medical. And third, the incentives, the focus of today's talk. There are a few key process elements as well. First is the low barrier care philosophy, which is really a harm reduction approach. And priorities are driven by the patient and often exquisitely focused on one or two things. There's a lot of cross-agency collaboration between our clinic, especially with housing agencies, substance use treatment programs, jail release planners. And importantly, even several years into this, we have a commitment to rapid modification and iterative improvement. The incentives are summarized on this slide. We give $25 cash for a visit with a lab draw up to once every 2 months, and started that initially with $50. We give $50 cash for viral suppression up to once every 2 months, which also started higher, as you can see here. And importantly, the cash incentives account for a very small proportion, less than 5% of the budget of the Max Clinic. We have several other things that are incentives or could be considered addressing basic needs. So snacks at each visit, meal vouchers we distribute up to once every 2 weeks, part of keeping people engaged in the clinic and with their case managers. We provide assistance obtaining unrestricted bus passes, and clothing, hygiene items, and makeup kits obtained through a donation. We initially started with distributing cell phones, but stopped that over time because it didn't work well. For cash incentives, there are a few key logistical issues to consider and surmount. The first of those is the funding source. How will this be paid for? In the United States, Ryan White funds a large proportion of HIV support services, and Ryan White funding cannot be used for cash incentives, for vouchers or gift cards that can be exchanged for cash, or things like grocery cards that can be used to purchase alcohol and tobacco. In the Max Clinic, we started our incentives with a research funding source through a CFAR supplement. But after we found evidence for impact, the Washington State Department of Health did assume the funding for these. The cash incentives are paid for through a flexible state budget for HIV and STD that doesn't contain federal money. And the other support items in the clinic are funded through ADAP rebates to the State Department of Health. A second key logistical issue is anti-kickback statutes. The US federal law prohibits exchange of anything of value in order to induce or reward the referral of business reimbursable by federal healthcare programs, which makes good sense and is needed within a pay-per-service healthcare system. This is a criminal statute that's punishable by up to 5 years in prison and exclusion of the health program from Medicare and Medicaid. So it's really crucial to abide by. The Max Clinic addresses this by partnering between Harborview Medical Center and Public Health Seattle-King County. And other examples may include partnering of a medical provider with a community-based organization. So public health provides the incentives as part of our HIV prevention programming, and public health staff are entirely responsible for dispersing and tracking the incentives with patients. Other logistical issues that aren't quite as large as those first two, but still need to be considered, include federal tax laws around remuneration over $600. For that, we need to file a W-2, and we would need to give one of those to each of our patients. And we need to avoid creating a perverse incentive for people to stop antiretroviral medication in order to get in the clinic and get incentives. So how we've addressed this is first keeping the total amount of payments under $600 per year, making this an invitation-only clinic. Cases are referred and considered, and this is largely based on a long-term pattern of difficulty engaging in care or adhering to medications. For the vast majority of people with HIV, cash of less than $600 a year isn't enough to induce someone to stop their antiretroviral medications. So we do try to minimize this risk, but importantly, I don't think we can ever eliminate it entirely. So evidence for impact in our population. First, I want to convey a bit about the complexity of the population. This shows some of the characteristics of patients enrolled in the first 5 years of the clinic. And the key takeaway is that the vast majority of people are struggling with either homelessness and unstable housing, substance use, primarily methamphetamine, and psychiatric diagnoses. And when you look at the overlay, there is a lot of comorbidity. 97% had one of these factors, and a full 42% had all three at the time of enrollment. So we compared outcomes, focusing here on viral suppression, among the first 50 patients enrolled in MAX, compared to 100 matched patients who remained enrolled in standard of care. And we looked at viral suppression in the year before enrollment or match time period compared to the year after. Among Max Clinic patients, just 20% had even one suppressed viral load in the year prior to enrollment. The vast majority of those were not virally suppressed at the time of enrollment. And 82% achieved at least one suppressed viral load in the year after enrollment. In the control population, viral suppression also improved over that time period, demonstrating the effectiveness of comprehensive HIV care. But when adjusted for substance use, psychiatric diagnoses, and housing status, Max Clinic patients were about 3 times as likely to have achieved viral suppression. Max Clinic is a combination intervention, as I mentioned, and so it's difficult to know exactly to what degree incentives account for the effect or any one component versus the combination. So one way we addressed this was with a qualitative study of patients to understand their perspectives about the Max Clinic and what was working for them. The key theme that came up when Max Clinic patients were asked open-ended questions about their experience in the clinic was how they felt they were treated and how their social circumstances were addressed. As for incentives, there was a lot of heterogeneity in the degree to which these were perceived as very important. But often there was discussion of them as a bridge to engagement that became less important over time. And you can see in the table here some description and quotes about the patient experience for 3 types of incentives. So lessons learned in the Max Clinic, I will finish up with those today. First, and most importantly, cash incentives are feasible and sustainable in practice. We've been doing this for over 5 years now with program funding. Incentives are the most controversial part of low barrier care. I've talked to a lot of audiences about this model, and I think it is important to note how often people are concerned about this issue, and it's not a cost issue. It is, again, less than 5% of the total budget. I think of the incentives as really key to engagement. It's part of what helps patients understand what's different about the Max Clinic compared to any other clinics they may have been to for HIV care before. Really important, and we learned some of this the hard way, is to be extremely clear and explicit about the rules around incentives and to have policies for some situations that may come up, like patients leaving the hospital against medical advice and coming straight to the clinic to get incentives. We need a policy for how to handle self-directed hospital discharges. And importantly, they may impede transition to conventional care. Over time, we've really come to recognize that the Max Clinic is not a transitional clinic, just like complex care clinics aren't transitional in many other populations. But for some patients who really get stabilized and could potentially go back to conventional care, this may be part of what makes them reluctant to do so. So if you'd like to learn more about the Max Clinic, I would invite you to view a 10-minute video that's on YouTube. And I'd like to thank you very much for your time and attention today.
Greetings, and thank you for attending our session on behavioral economics and conditional economic incentives. My name is Mike Sterrett, and I'm at the National Institute of Mental Health in the United States.
My name is Susan Borkaber, and I'm from the Fogarty International Center, and specifically the Center for Global Health Studies. So building off of the previous 4 sessions, we're excited to host this panel with esteemed researchers, technologists, and government and public officials. This group will discuss moving from research to program and policy, and then some key directions for further research and implementation of behavioral economics and conditional incentives in HIV treatment and prevention delivery. So without further ado, let's start by speaking with our researchers. So first, Dr. Omar Galara, the Associate Professor of Health Services Policy and Practice from Brown University. Then we'll hear from Dr. Sebastian Linnemeyer, Senior Economist and Professor of Policy Analysis at the RAND Corporation. So we've heard a lot about behavioral economics and conditional incentive research. From your own work, what are lessons that you all have learned? And what would you tell someone who's just getting started?
Yes, hi, Susan. Thank you for having me. If I was starting again, I think I would still work with key populations. So a lot of my work has been in Mexico with male sex workers who are at very high risk of HIV infection. We've documented 5 per 100 person year, so among the highest in the world HIV incidents. I would still do a lot of formative work to do this work, asking them about, what type of incentives are better, what levels with various economic incentive tools. What I would perhaps change in retrospect, with 2020 vision, is to focus on single, relatively easy to do interventions if those are possible, right? So in retrospective, looking over the last 15, 20 years, we can see that it has worked better with one-off interventions, right? So incentives have worked a lot better, say, with male circumcision or with HIV testing, or with behaviors that can be more easily verifiable, such as perhaps taking a pill every day, if you can measure that somehow through hair or through blood. So that would be an insight that if I could, tell my younger self 10, 15 years ago, or somebody who's starting, to try to focus on very discrete interventions, discrete behaviors for which the incentive may work better.
Thank you so much. Dr. Linnemeyer?
Good morning, and thanks so much for having me. I think I actually have something to say about what Omar said about the short-term versus long-term, but let's leave that for later. Thinking back with 2020 or 2022 vision, I think I started my work with kind of a focus as the incentives as a tool. And since then, I've come to appreciate behavioral economics much more as a framework that really helps us better understand human behavior than kind of what the traditional approach was to human beings and health consumers as being these rational sort of machines that always respond to information and price. Very similar to what we've heard in the first presentation by Dr. Thirumurti. So from a policy point of view, to me, that means that we have a much larger toolbox than we had, let's say, 10 years ago. We have incentives, but very different incentives, as I will get back to, not just, monetary payments. And from really kind of, because my work is really all about incentives, for me also the notion, the conceptualization of incentives has broadened very much over the last couple of years. I started out with these relatively traditional price drawings, but over the last couple of years, I've really realized that there are so many other drivers of human behavior. So while we still talk about incentives, most people think about incentives in terms of monetary payments and rewards, these sort of things. But I think it's pretty clear that we're driven by so many other things, such as, recognition in a group, or peer pressure, or pressure to conform to our better selves. So I think that is a lesson that it has been very important, that that incentives are really much, much broader than what we were thinking about when we were kind of in the contingency management world 20 or 30 years ago.
Thank you both for your perspectives and how things are evolving and changing in this very interesting, very exciting area. Let's also open with a question for our implementers. And I'd like to introduce now several participants in our panel. This includes Natalino Moenda, who's the founder and executive officer the founder and chief technology architect for Rationale Incorporated, which is a communications software company with offices in Tanzania, Nepal, and Singapore that provides digital solutions for data collection and program management. Also, we'll be speaking with Dr. Katie Godfrey, who's the Senior Technical Advisor for HIV care and treatment at PEPFAR in the United States. And further, we'll speak to Dr. Prosper Niao, who is currently a consultant for Prosperous Nation in Tanzania, and is also a technical lead for the Tanzanian Ministry of Health. Welcome to each of you. To our question, we see in our prior presentations in this session that there's a growing evidence base around the use of behavioral nudges and conditional incentives to drive behaviors that would support HIV treatment and prevention. Given that we have this growing evidence base, we also see how sometimes the use of conditional financial incentives can be a lightning rod in the implementation of these types of approaches. So we'd like to ask each of you to reflect where do you see this field standing today? What would you need to see for us to move from our current research into the actual implementations of programs and policies that deliver these kinds of nudges and incentives? And let me start with Natalino, to you. What would you like to see as we move from research to program and policy?
Thank you. Thank you for having me. And good morning to you all and good evening to myself. I think it's pretty inspiring to see that we've established a pretty strong proof of concept on the incentive-based interventions here in Tanzania. And I think the challenge is not really scaling the tech. The tech is already there. It could easily be replicated. But I think when you have more and more people enrolled, so I'm basically answering this question in the subject of scaling. Scaling is what I would obviously like to see. How can this technology impact more and more people? But as you bring in more people, the pool of the incentive, which is cash at this stage, becomes larger. And ultimately, the $1 million question always comes is going to fund that pool. So I think in the world of tech, when a proof of concept is established, there's this rush to put in a lot of resources so that you can scale it. It could impact more people. But I think sometimes in the public sector, the subject of sustainability comes too early. I think the subject should be scalability before sustainability, because when you bring sustainability too early in a conversation, what happens is that you reduce the speed of scale. Like the technology almost plateaus to a certain extent. And since the proof of concept is established, I think what I would be really interested in seeing is how do we find ways to discuss on a policy level, I suppose, scalability before sustainability. And I know it's easier said than done. In the private sector, it's very easy to just think of scale. But I think I do understand that there's a whole ecosystem when it comes to scaling a great technology. And I think just following through what Sebastian said, I think if we could also start thinking of cash not being the main commodity here, and maybe better health. So I think there's almost like this mental shift to the people who are in this program for them to consider health, being healthier, as the major commodity. And I think there's a lot of investment that has to go down on educating people that health is more important than cash. Thank you.
Thank you very much. Let's turn to Dr. Godfrey for your comments.
Thank you very much. Very interesting discussion. So people may know that what you said about the cash incentives being sort of a lightning rod really resonated with me. They certainly have been in PEPFAR, cash incentives for particular activities. And so for that reason, PEPFAR has not really gone in that direction. I do like the notion of non-cash incentives. And I guess what we need to know is really whether or not they were as effective. I was taken by Dr. Galarraga's remarks about really showing specific incentives with measurable deliverables that really, that you can really measure outcomes very carefully. So I think that for us, the non-cash incentives with measurable outcomes, measurable positive outcomes, I think that would be probably the next step that would be needed for us to kind of embrace it completely. But, it is, we'd like to believe that health should be its own reward, but there's so many competing things that people have in their lives that I think it's kind of simplistic to kind of focus on, if you do this, you will be healthy in 30 years. I don't think that that's really a message that resonates well with many people who come to our programs. So I'll stop there and thank you very much for the question. Over.
Thank you. Let's turn to Dr. Nial. You've uniquely had experience in both the research as well as in the Ministry of Health. What is your perspective on taking this work forward into implementation?
Yeah, thank you everyone, and good morning everyone, and good evening to Natalino and myself from the Eastern Africa. It's evening now. Yeah, well, I would say that for myself, we have two issues. One is that now there is more evidence that, of course, economic incentives, cash transfers are not for everyone. And since they're not for everyone, I think what we will need to see is precision targeting in terms of implementing conditional cash transfer or economic incentives to specific population. And I'm saying this based on my experience working within the HIV program, but also doing extensive research within the PHIV cohort. It works really well with people who I would say that really need the incentives to nudge and encourage those intrinsic behavior where they can remain on treatment. And we are seeing this with the evidence that we've seen, especially during the early period when someone is identified with HIV infection. And that phase is really a formative phase where you need more than intrinsic motivation to continue to remain on treatment. And we see that economic incentives, cash transfer, and behavioral economics works really well there, where we have these additional nudges and additional inputs, stimuluses that can actually enable a person who is newly diagnosed with HIV first to start that treatment, but also to continue and form that behavior that has long-lasting effect. What we have seen from the work that we've done is that with short-term economic incentives or behavioral incentives, the effect is actually long-lasting. For example, in our previous studies, we've seen that 6 months to 1 year after the incentives have been withdrawn, there is sustenance of that effect that we've seen. And we believe it is because we implemented this intervention with that window of period where the patients really needed this. And for us, it has been unique because when you look at the continuum of care, of treatment, it's very difficult to pinpoint exactly a particular intervention where, for example, where you have economic incentive for VMMC or for other interventions. Here it's an amalgam of interventions that has to be implemented. And what we are doing is that we're incentivizing the patients to have that behavior to come back to this facility. And cycling back to the technology, we are seeing the role of technology more and more very important because one, as I've said before, that the economic incentives is not for everyone. And you have to be able to do that precision targeting. And here technology actually can enable us to dig through the data that we have and really identify people who would benefit with this intervention. In particular for Tanzania, what we are seeing for those who are starting treatment for the first time, but for those who also either likely to drop out of care or would not attain viral suppression at 6 months or 12 months. So in order to deliver to that population, we need precision and technology comes in. And once you achieve precision, what we are seeing is that the program is going to be much cheaper because you don't implement a program for everyone. You have a very specific population that you can work with. And then the second thing, which I think is unique for the work that we have been doing, is that we have established the strong association between conditional cash transfers and viral suppression, which I think is quite impressive, that we can show that people who receive conditional cash transfer in the first few months of treatment rapidly achieved viral suppression, and that suppression was maintained over time. Yeah, so maybe to conclude, I think what we'll need now, one is to send a message very clear that incentives is not for everyone. And we are at a point where I think we can leverage the existing tools and technology where we can improve precision, cut costs or minimize costs of the intervention itself. And since you have demonstrated that most of these incentive-based interventions actually have a tangible impact, I think we're at a stage where this can really be adapted from policies, from research into policies and practices. Thank you.
That's very helpful. Thank you very much.
Yes.
Susan.
Yeah, thank you. I think you all pointed out some real world issues that that you're all encountering as you kind of think through how these can become part of a program and policy. And I think this really kind of begs the question, which is, you know, what are the research gaps? Like, what is going to help us kind of move, you know, what is the evidence base that needs to be established in order to have more of these kind of successful programs and policies? And I'll start with Dr. Gallara.
Sure, thanks. I think given what we've seen in terms of the very rigorous systematic reviews and the mounting evidence over the last decade and a half, I think there are some interventions that at this point are solid efficacy results that are beyond proof of concept. And as we just heard also from Prosper, I think it's time to think about, and from Natalino, start scaling up. And so I think we could, in this research area, move to a phase where I would call it, the implementation science research phase, where especially for male circumcision, for HIV testing, and for adherence, both to antiretroviral therapy and perhaps for PrEP, which is another area where we're working also in Mexico, incentives for PrEP uptake and adherence. But since we've demonstrated in various countries adherence for ART, as well as I said, this one-off special interventions such as male circumcision and HIV testing, I think for those in particular, I think it's time to start thinking how to scale it up in the best way. So the field of implementation science has a lot to say, right? And how you do this, and you start testing different ways in different settings and what facilitators are better. A caveat would be to think about just heterogeneity, because still, even though the literature has grown as we saw the results, starting from very few studies to 20, 30, and I think now there were about 50, 60 studies per year, it's still, we don't have solid results everywhere, right? We have good results in some countries, in some settings, with some populations. So I think we need to be very careful. And I like this language that we're hearing of precision targeting. I think it's very important not to just think about the target populations, but also the settings where this has worked. I think in my own work, which I started in Mexico, but then I branched out to move into working with colleagues in South Africa and Ghana, and now in Kenya, in different countries, different settings, different populations. And so you have to think very carefully on this mixture of things and how different levers affect different outcomes. And I think that's exactly what, implementation science can help us do, how to get to an outcome based on different combinations of, of course, the outcome that you want to intervene on, the outcome, the intermediate outcome that you want to condition on, the level of the incentive, to whom, for how long, for what, and then in what context, in what health system you are operating. So these are all very important questions that implementation science can help us with.
Yeah, I completely agree. I think that those are some really good and very kind of broad, but also quite specific areas to focus on. Dr. Linnemeyer, what do you think?
Of course, I agree with what Dr. Galarraga just said. But one thing I've been thinking a lot about is that, as we also heard in the presentation by Dr. McCoy, a lot of the interventions that we see that work best are those that encourage very short-term behavior change or one-off behaviors such as circumcision or HIV testing. But the conundrum is that we all know that the most pressing public health problems these days, including in HIV, is chronic behavior change, where people need to change their behavior and, for example, take their ART medications lifelong. So I agree that we have a much better evidence base on those kind of more short-term behaviors. But what we really need, and not just for HIV, but pretty much most public health problems, in the US and abroad, including diabetes, heart conditions, obesity, is really how do we achieve long-term behavior change? And as we're talking about incentives, what I typically see in my work, and that's a relatively well-established outcome, is that incentives seem to work while you apply them, but once you withdraw them, the target behavior typically goes back to baseline. So that's, of course, kind of a mixed bag. Good news that incentives work, bad news that they typically don't work for very long. So I think kind of one response to this would be, okay, let's provide incentives for 20, 30, 40 years, but I think this would likely not be effective nor cost effective. So what I've been thinking a lot about in the last few years is how to combine and integrate short-term behavioral change approaches with established approaches from other disciplines. And to give you one example, for example, in the psychology literature, we know that a lot of those people who successfully manage chronic conditions are those that have strong habits, that very regularly, for example, take their medication every day at the same time. The problem is in the psychology literature is that it takes about 2 to 3 months to establish these sort of health habits. And a lot of people drop out during this period of time. And behavioral economics, I mentioned before, to me is a framework to understand human behavior and decision-making. And so even those 2 or 3 months, people suffer from a lot of these sort of behavioral biases that behavioral economists and behavioral scientists study, such as present bias that we get, as Katie mentioned, we get, there's a lot of other priorities in the short term. Even though in long term we want to be healthy, but in the short term there's a lot of things that we are subjected to. So, for example, one integration I'm currently working on in 2 studies in the US and in Uganda is to use incentives very short term for those 2 to 3 months during which healthy habits are formed, this habit formation phase, with the idea that once the behavior is automated, we can withdraw the incentives without seeing this reversion to baseline. So that's kind of, I think we need to crack that nut of how to get to long-term behavior change. And I think it requires some kind of creative combination of approaches from behavioral economics to kind of support and supercharge more traditional approaches, such as habit formation or, a range of other interventions where we've seen they can work, but a lot of people have a hard time forming it. And we can kind of then use incentives to support these traditional approaches. That's kind of what I'm thinking about currently a lot.
Thank you. No, I think that's really helpful. And I think it gets at some of the points that our implementers made. In fact, this brings me to Dr. Godfrey. You specifically mentioned some of the concerns that you've seen. What evidence and data would PEPFAR need to see to kind of, or what, maybe I should ask, what would you find persuasive that might, increase investments in behavioral economics?
So just to back up just a little bit, I lead a group that's concerned with treatment continuity. That's the sort of newish term that we're using for adherence, and we're thinking very much a lot about habit formation and how to really implement that. So what you're saying is really resonating with me. Similarly, it's almost, what Prosper was talking about, it's almost like there's this imprinting thing that has to happen over a short period of time. And then, that you have this habit formation and then you kind of withdraw that incentive. I think that's, PEPFAR is a very blunt instrument. It really is. And what we do is we have, it's success, it's reason for success, and it has a lot of drawbacks. So we have for treatment, in fact, we have one pill for absolutely everybody that is taken by everybody, and so so the messaging is simple. Anyone can do it, and that's how it works. This notion of precision public health, in other words, targeting the specific targeting that we're talking about with an evidence base for its effectiveness, I think is really what we need to do and what we need to see. I really, I do think that it is really, we're moving to, chronic disease management, and chronic disease management is really difficult, particularly in specific age groups. So I do think that, you know, learning the lessons from internal medicine and from other chronic disease management is really important. I've tried to bring that into our work here. So I guess what if you're asking me what would I find persuasive, it would be the specific we can't do, you know, these targeted interventions for everybody. For what population are these effective, and what is the real-time gain for this population? So in other words, if we understand that targeting adolescents for 2 months, or, you know, it results in long-term behavior change, that's a helpful piece of information. But you know, I mean, so it's really which groups, what incentive, and at what time. And I suspect that a lot of that is going to be sort of have cultural implications and be locally important. So it may be that it's even more precise. It's not just a population, but it's population and geography. I think those are the kinds of things that we need to hear about. Does that answer your question, Susan? I hope so. Thanks.
Yeah, it really does. Thank you so much.
Excellent comments. As we begin to wrap up, let us ask each of you for some of your top line recommendations as we move forward with research and implementation around behavioral economics and conditional incentives. Let's start with Dr. Niao. Can you share something with us very quickly in terms of what your top line recommendations are as we move forward in this area?
Yes, thank you very much. What I would recommend is really to use the existing tools that we have. There is more and more evidence right now on the impact of behavioral science and economic incentives on healthy outcomes. And we are seeing that strong from our country. And what we can leverage on, for example, for Tanzania, is the robust data that we have that is longitudinal, where we can use that data, you know, to determine who really meets that criteria or who is at the risk of fall off. And I think that data provides an avenue of more and more ways that we can optimize the program and also target the program to those people. And this would essentially, for example, when we can adapt more analytics, more predictive analysis that can actually identify this cohort of PHIV on treatment that we can really target with these types of intervention. So I think let's open up our mind, you know, be on the lookout, adapt new tools. But also I think there is something that we usually tend to forget when we talk about economic incentives, cash incentives, and we think that these should be expensive big programs. No, I think the you know, evidence is more and more towards making it smaller, more nimble. But again, there are a lot of programs that we do implement that are quite expensive. We do not see similar impacts that we are seeing with this, of course, as you mentioned, that's a lightning thunder experience. Thank you.
Your points are much appreciated. Thank you so much. Let me also pass to Dr. Godfrey for your top line recommendation.
Well, I think I'd like to understand more of how to implement this notion, the science of habit formation at a larger scale. I think that that's really going to be really one of the evolving and evolving areas of scientific research that we can then marry to the implementation platforms. I really do appreciate and value the contributions of our colleagues on this call, and I really do think that it's a really watch the space for me. We're so far down the line, but the science of it all is, and the social science of it all is extremely interesting, and we will be watching very carefully. Thank you.
Thank you so much. Natalino, what would you like to leave our group with today?
Yeah, I think one of the things I've learned a lot, and I think we've heard this word of precision targeting. I think it's a very beautiful statement from Dr. Prosper. And, you know, I kind of try to get some learnings from the private sector. And I think how do we, for these people that we can be more precise on what their needs are, is how can we also bring in the private sector to contribute into sort of giving their products or services as a part of the reward, the incentives for people to extract. I think when you look at some of the most successful reward programs in this world, basically means they have a larger network of things that you can actually be able to extract your incentives. So as opposed to it just being cash, like how can we bring the private sector to bring an even larger pool of a reward network for some of these people, maybe some of the people who are like moving more into the middle class. So that way, it's going to make it cheaper, first of all, for scaling it, and it's also going to make it more sustainable. Because again, it's like this shift of cash into something else. If I'm gonna engage in a program and I'm going to be able to extract points, for example, how can I then convert these points into a much larger network from private hospitals and so on and so forth? That way, it also makes the program more diverse, I suppose. So that's it will be very interesting. But I know my ideas are very ambitious. I get that, and they're overly creative. And I think they're going to take a very long time until we actually see the private sector come into play. But it's a nice wish. It's a nice wish. Thank you.
It's important to have some aspirational goals, and thank you for that. We appreciate it. To conclude then, let's have final comments from Dr. Lindemeyer, followed by Dr. Galarraga.
Thanks so much for all these interesting thoughts. For me, I absolutely agree that we have more and more data on electronic health records and so on that allows to basically unpack heterogeneity and what works for whom, precision medicine and these sort of things. But I'm always very much focused on conceptual things. So one thing I wanted to say is that if we want to get to a generalizability of the evidence base that we currently have, I think we're not doing a great job leveraging all these different, most of the time, RCTs that exist to kind of find out what works in what setting, because there is a large local component and an implementation component. Rewards in Uganda in my studies look very different from what I do here in the US, even though the conceptual pathway is the same. It's overcoming present bias and guiding people in the short run in order to get them to long-term healthy outcomes. So for me, the answer, and that's just for me as a researcher, is to try to test out conceptual pathways rather than programs, because the more things you pack into an intervention, the harder it is to unpack it afterwards. So that's one thing. Second one, of course, we have to keep measurement in our mind. Incentives only work if you can measure the outcome that you're incentivizing. And in that regard, I wanted to say that I've seen very, very few cost effectiveness analyses, because we're talking a lot about scalability, sustainability, yet there are very, very few interventions that actually kind of contribute to this evidence base. Because I think the knee-jerk reaction of a lot of policy makers is that incentives cost money because the money is very visible, right? It's very tangible, even though a lot of other programs, that use motivational interviewing or so also are quite expensive, right? But for incentives, the cost is very visible. So I think the more evidence we have that they actually are cost effective and are not that costly, I think that would be a very pragmatic kind of step that we should encourage, maybe also on the funder side.
Excellent. Thank you so much. And finally, Dr. Galarraga.
Yes, it's fascinating to hear, for example, this issue about, for example, PEPFAR being a blunt instrument. I think incentives are also a very blunt instrument, and I think that, but they can be very effective, and so I think we need to sort of put a big red sign, right? Handle with care, and I think it's an issue of cost effectiveness to demonstrate that they work. I mean, it's interesting also the comment that Sebastian made about the incentives working while they are in place. But of course, if I take an aspirin for the headache and then the headache comes back the next day, why would I think that the aspirin that I took yesterday would work, the next day? So it's the same thing. Why do we think that this very blunt instrument would outlive, its present effect? And it's a threshold that we don't have with any biological treatments, right? So it always makes me think about that. But I agree that we need to do, as researchers, better job of showing what's effective, as we've seen in the literature, in terms of one-off interventions such as male circumcision or HIV testing, or things that are done every day, such as adherence, but to show how actually countries and programs would save money in the long run. I think this needs to be demonstrated better, right? That you invest now and that you're actually saving money 5 years from now, 10 years from now. And so I think when we are saying, okay, well, it costs too much money now, I think we're being a little bit of sort of this idea of being wise penny and pound foolish, right? That we don't want to invest a little bit right now to save more in the long term. So I will leave you with this idea of political will. How do we get more political will? Because in some countries you have none, in some countries you have some, and in some countries, you know, they're going all the way. They've realized this and they're trying to really scale it up.
Thank you. Thank you, Dr. Galarraga, and thank each of you on behalf of Susan and myself, as well as all of our attendees at this satellite session. We really appreciate your comments. We'll now have to close our discussion session, and so we will pass it to Rachel Stirk and to Diane Rausch for their conclusion. Thank you again for joining us.
We'd like to share some conclusions and takeaways from the session.
Key takeaways are success of HIV treatment and prevention depends on human behavior. Behavioral economics facilitates health behaviors through nudges that leverage non-rational thinking and mental models. Behavioral economics and conditional incentive approaches demonstrate impact with the strongest research evidence in HIV testing and antiretroviral treatment adherence. And programs are now advancing behavioral economics and incentives approaches in South Africa, in Delilah Nudge Unit, and the US example Max Clinic, and globally, often in combination with other interventions.
Future directions for research and practice include increased attention to nudges beyond conditional finance incentives, use of behavioral economic tools and approaches to foster habit formation, precision targeting to identify those who would most benefit from these approaches, and improved attention to cost effectiveness and the potential for broader scale up. We'd like to thank all of our speakers and our NIH colleagues and partners for participating in this satellite.